Hello, everyone. I am Mendy Minjarez. I'm an assistant professor of psychiatry and behavioral sciences at University of Washington, as well as the director of the Applied Behavior Analysis Early Intervention Program at Seattle Children's Autism Center. And I am going to be giving a webinar this morning on toilet training for children with developmental disabilities. I'll start out by just giving a quick overview of what today's topic will be. We're going to talk a little bit about toileting readiness. Then I'm going to spend most of the time talking about procedures called habit training, which are an applied behavior analysis-based set of procedures for teaching children with developmental delays and developmental disabilities how to learn toilet training. We'll talk a little bit towards the end about common problems, and then I do have some slides at the very end about resources related to toilet training, including some reading and also some websites. So to start us off, it's helpful to talk about some of the challenges that children with autism and developmental disabilities have that interfere with toilet training. So some of the more obvious ones are related to the symptoms of autism and some of the challenges that children with autism specifically face, things like communication problems, also literal patterns of communication. There's a lot of challenges in how we communicate with kids about toilet training that can be particularly difficult for kids with autism and developmental delays. A lot of sensory issues can also interfere, so things like how aware kids are of the need to void in the toilet, what kinds of clothing they are and aren't willing to wear, what kinds of challenges they might have in the bathroom from a sensory perspective, kids who have fears in the bathroom, especially in the public bathroom, things like fear of the sound of the toilet flushing, fear of sitting on the toilet. A lot of these kinds of things can interfere. A lot of sensory sensitivity and kids who are easily overstimulated is often a factor with kids who are trying to toilet train in the context of autism. The need for toileting routine can be a big one. So kids with autism who maybe develop a certain routine around toileting, but it's not the routine that we want them to engage in. Parents will oftentimes report that kids are very rigid about the patterns in which they are toileting, for example, being in a certain place in the house or insisting on wearing a diaper, and that it's hard to break them of those routines. Sometimes kids with autism and developmental disabilities have problems with motor planning, which can, of course, interfere with things like getting up on the toilet, getting off of the toilet, again, some of that awareness and ability to acknowledge the need to void the bowel or the bladder. Oftentimes deficits in imitation skills can interfere. When you think about how typically developing kids learn toilet training, a lot of it has to do with seeing other people engaging in toileting routines, whether that's at home or in preschool or early childhood settings. And kids who don't imitate well will oftentimes not be picking up on aspects of the toileting routine the same as typical kids would. Oftentimes anxiety can interfere, and this can be for a variety of reasons, some of which are sensory-based, some of which oftentimes have to do with rigidity in routines. Sometimes we don't know what the source of the anxiety is, but we certainly know that kids with autism are more prone to anxiety compared to developing kids. And then finally, problems with generalization and maintenance. So kids who will learn skills in a certain setting or under certain conditions, but not generalize those skills to other settings or maintain them over time. And children with autism are at particular risk in that area, which can certainly interfere with learning the toilet training routine. So we're going to talk today about some procedures for how we can teach kids who have some of these challenges. One of the things that people oftentimes ask about with regard to toilet training is how do we evaluate toileting readiness in kids who have developmental delays? And there are a few different ways, although the procedures that we're going to talk about today, we don't necessarily have hard and fast readiness criteria. These are procedures for kids who are struggling to learn, who have not learned successfully from other procedures, and oftentimes these procedures are sort of the intervention of last resort for kids who are not showing any awareness or readiness. So the readiness factors that I'm going to go over are certainly helpful, but not required to do this kind of a toileting intervention. So certainly age, chronological and or mental age of about 2 years is helpful. Around 2 is about the earliest that typically developing kids toilet train. And so knowing that a child who's delayed has a mental age of about 2 years is definitely helpful. Again, not a requirement. Awareness is really helpful. So awareness of being wet, awareness of the toileting routine and what the components of that routine are, awareness of when a child needs to go, awareness of other people using the toilet and the fact that that is a normal behavior that other people engage in. Again, these things are helpful but not a requirement. It can be useful to notice some physiological factors, so things like dry periods, which can be hard to evaluate in kids who are wearing diapers, but noticing whether or not the child's diaper stays dry for a period of time, and then whether they seem to be voiding all at once versus whether they seem to be voiding small amounts, over time and maybe are not demonstrating really good urinary continence yet. Regular bowel movements is also really helpful. Oftentimes bowel training is harder than urine training, and kids who have regular bowel movements, who have them at predictable times of day, that can be really helpful in their training. And then certainly motor skills. Children have to be able to sit up. They have to be able to get on the toilet. They have to be ambulatory enough to get to the toilet. And kids who have significant motor delays are going to have a harder time, or certainly they're going to require a lot more adult support than kids who are motorically about where they should be for their age. The other thing that's important to consider is medical factors. So there are a few medical conditions that could make toilet training more challenging or even contraindicated. So things like constipation, including a history or a current, scenario where the child is having painful bowel movement. Now, this doesn't necessarily make toilet training contraindicated, but it can certainly make it harder, particularly because kids who have a history of painful bowel movements and constipation are going to be much more likely to have anxiety and avoidance about toilet training. Kids who have this history oftentimes have fear associated with being in the bathroom or being on the toilet that causes them to be avoidant. So some intervention to address that fear might be important before starting a process like habit training. Sometimes there's a medical reason for urinary or fecal incontinence, and so those are important things to rule out. In a kid who has an otherwise benign medical history, this is unlikely. But in kids who have history of other medical conditions, of physical disability, kids who have a history of walking very late or other kinds of significant motor delays, kids who have cerebral palsy, kids who are in wheelchairs or who use walkers, might also have associated medical reasons for challenges with continence. The other one is a history of urinary tract infection. Urinary tract infection not only can cause pain, which can again cause anxiety and avoidance, but it can also cause really frequent urination, which can make it difficult for kids to hold their urine, particularly when they're learning toilet training. So ruling out urinary tract infection and making sure that a child is physically healthy before starting toilet training is really important. Again, a child who has been otherwise healthy, these are probably not concerns, but in a child who has any of these issues in their history, it would be important to address them before starting toilet training. So I want to talk today about a procedure called habit training. Habit training is a process or a protocol, if you will, that's grounded in the applied behavior analysis literature. Very tried and true. It's very well researched. These are procedures that were developed back in the 70s and have been very well validated and documented. And surprisingly, they're not very well disseminated, which is why this webinar is a really important one, I think, for us to have available for families, because so many families come in and say that their child is not yet toilet trained and that they don't have any strategies for knowing how to do it. And so many clinicians also don't have any strategies in their toolkit. And in fact, this is a tried and true set of procedures that works really well if it's done consistently. So we're going to spend the bulk of our time today talking about what these procedures are and how to do them. So habit training, what is it? This is based on a set of procedures that were first and most thoroughly documented by Nathan Azrin and Richard Fox, as you can see from the book cover that is on this slide. These procedures are very systematic and very protocol driven and very intensive. So this process begins with an intensive upfront training, sort of a boot camp approach, if you will. Although it is different from a lot of kind of intensive approaches that that parents of typically developing kids might use or that you might hear about from talking with other parents, because these procedures are really systematically laid out. So although it is the intensity that is important, it is equally or more so important to have the consistency and the thoroughness in the procedures themselves. It's not just about taking the time to dedicate. It's about being really consistent and thorough in your approach. So the points that are listed on this slide are the points that we're going to be talking about. We're going to go into a lot more detail in each one. But this is an approach that involves starting off with no more diapers. And we'll talk a lot more about that because that's really stressful for a lot of families. But it is an approach that starts with putting the child in underwear and not using diapers, because the child does need to feel when they're wet. It's an approach that involves putting the child on a toileting schedule so that you're taking them to the toilet on a regular basis. And then one of the things that's unique about this approach is increasing the child's fluid intake, because we're trying to increase the number of opportunities the child has to practice the correct behavior being voiding in the toilet. So typically, most kids probably urinate between, anywhere between maybe 3 and 6 times a day. But from a learning perspective, that's not a lot of trials when we're trying to teach a new behavior. So what we're trying to do is increase the child's fluid intake so that we can increase the number of opportunities that they have to void in the toilet and increase the intensity of their learning because they're having more learning trials. And we'll talk more about that. Then the process uses rewards for successful completion of toileting. There's a procedure called dry pants checks, which we'll talk about. There's a procedure called positive practice for accidents, which is how accidents are addressed and how they're used as a teaching and learning opportunity. And this upfront training lasts for about 2 days. And the goal of the upfront training is to get the child to a point where they understand that they should not void their urine or void their bowels until they are sitting on the toilet. They may not be initiating the routine at the end of 2 days, and they're probably not going to be communicating with others to let them know that they need to use the toilet. What we do expect them to be able to do is to hold their urine and hold their bowel movements until they're on the toilet, and to be essentially what some people call trip trained, meaning that they know to wait until someone takes them to the toilet before they engage in any kind of voiding behavior. So this process should decrease accidents a lot, and it should increase successful voiding in the toilet a lot, but it's not necessarily going to fully result in completion of the entire toilet training process, including initiation of the routine on the part of the child, or communication on the part of the child that they need to use the toilet. Those are oftentimes skills that come later. And then once this initial upfront training is complete, the continuation relies on ongoing prompting and coordination across settings. So it relies on the adults who have taught the child to begin with to communicate with adults in other settings in order to ensure that everybody understands what the child's current skill set is once they complete the 2 days of training, and what kind of prompting and ongoing practice they're going to continue to need across settings. So we'll talk more about that. So when do we use habit training? We talked a little bit about general readiness factors, but when to use habit training is oftentimes a question that people ask. So one criteria for when we could use it is just when you want to do it quickly. I've done this with typically developing kids. I've done this with kids of all functioning levels, with many different diagnoses. And sometimes it's just that we want to train them quickly. We want an effective strategy that's efficient. And for kids who are typically developing or who are less impaired, cognitively by their delays or by their autism, they typically learn pretty quickly using this kind of strategy. For kids who are more impaired, this is a really helpful strategy when the child has not learned from other techniques. So parents who will come in and say, we've tried everything, we've tried all the usual strategies, we've tried all the strategies we use with our other kids. The child with autism still hasn't learned toilet training. What do we do? This is a good strategy for kids like that who haven't learned from other techniques. because this is really systematic, it's really intensive, um, and it's pretty much the only way that I've seen kids learn toilet training who haven't learned from other techniques. This is the strategy that I try when the awareness of the need to void is not present. So in kids who are not showing that awareness and not showing those prerequisite skills, but we still want to try something, this is the strategy that I try. And I have oftentimes seen kids who did not demonstrate awareness be successful with toilet training. And this is oftentimes surprising for parents because they've been told by other clinicians or practitioners or teachers that the child isn't ready, that the child can't learn toilet training, that they're not showing the readiness skills and so on. And all those things may be true, but I have seen kids like that gain toilet training skills using these strategies. Um, when kids don't demonstrate awareness of being wet, that's another, sign of concern about how well they're going to learn. But again, these strategies have been effective with kids who are that limited in their awareness. And then oftentimes when kids are either, older than about 5 or 6 and not yet trained, or when they're older than about 5 or 6 and they're delayed such that their mental age is between about 2 and 4, these are the strategies that I find to be the most effective. So I've done these strategies with teenagers who, were quite delayed and who were maybe functioning at sort of like the preschool developmental level. I've done this with young adults. And I think that if they're going to learn using any set of strategies, it's going to be this set of strategies because it's really geared around the kinds of techniques that we know are useful for individuals who are really having a hard time learning new skills. So preparation is everything when we're doing habit training. This process is so intense that an adult is going to need to be monitoring the child constantly while it's going on. So being prepared is critical because you're not going to be able to stop midway through and gain more supplies, for example. Go to the store or, take a break to go to an appointment or to take care of another child. Somebody needs to really be paying attention at all times to the child who's being trained. So being ready for that is really crucial to the success of the program. By the same token, choosing an appropriate time to start then becomes really important because if we don't choose an appropriate time, then we may not be appropriately prepared. I always tell families, you're better off to wait, even if you have to wait another 3 months or another 6 months, you're better off to wait until you can find an appropriate time where there's not scheduling conflicts, where there's not major family stressors, or you're not planning to move houses, or there's not a big break from school coming up, all these things that disrupt routines and schedules and learning for kids who are developmentally delayed. You're better off to wait until you have an appropriate time window where you're not going to be disrupted by anything like that. So I think it's very important to carefully choose when habit training is going to be conducted. It's really helpful to take data to determine the toileting schedule prior to starting. So while you're doing habit training, the child is going to be loaded up with fluids. They're going to be drinking a lot more, hopefully, than they normally do. That's going to be a very atypical kind of a schedule of how often they need to urinate or have bowel movement. But what we want to know when we're done is how often are they urinating under normal circumstances, because you're going to need to continue prompting, and we're going to want to know how often the child needs to be prompted once they're done after the first upfront 2 or 3 days of training. So understanding that by taking some baseline data, prior to starting the process is really helpful. We want to make sure we obtain materials, and I'll go into detail about what all of those materials are. We want to make sure we have a plan for a dedicated adult to attend to the child. Again, we need somebody who can monitor the child really closely the whole time it's happening. Multitasking and distractions or having to leave the house are factors that will really sabotage this process. So you want to have a plan to stay at home and not go anywhere for 2 to 3 days, and to have somebody really dedicated to the child. So this might mean making child care arrangements for other children. This might mean canceling appointments. It might mean choosing a weekend really carefully where nothing else is scheduled, and so on and so forth, so that the adult who's engaging in the training can really closely attend to the child being trained. And then you want to have a plan ahead of time for coordination across settings. So, once you've done the upfront 2 or 3 days of training, then, of course, on the third or the fourth day, you're going to be sending the child back to their normal schedule. They're probably going to be going back to school, going to therapies, going to child care, and we want to have a plan for making sure that other adults in those settings are aware of what's happening and what kinds of support the child is going to need when he or she returns to those settings so that they can support your efforts. There are definitely going to be some ongoing steps that need to be taken following the upfront couple of days. So kind of a checklist for getting started. The first thing that you definitely want to make sure you do is to read a toilet training manual, and there is one listed at the end of these slides, and or just understanding the procedures in detail. So even listening to this webinar will give you a very, very good idea of what the procedures are that you need to be engaging in. The toilet training manual that's listed at the end is also a helpful resource, particularly because it's one that you can share with other people and they can look at it or read it on their own time or in small doses and refer back to things if they need to. But I would say that the manual and the webinar together would be more than enough to prepare you with the information that you need. You want to rule out medical causes, like we talked about earlier. You want to determine who's going to coordinate the program, meaning who's going to prepare, who's going to oversee the actual training process with the child, who's going to communicate with other people in other settings about what they need to know when the training is complete. You want to contact those caretakers across settings. You want to prepare your materials, which we'll talk about. You want to assess mobility and dressing skills, so make sure that you're removing any barriers to those things that might be present, particularly with things like what kinds of clothes the child is going to wear or what kinds of stools or other things you might need in the bathroom to facilitate the child's mobility. And most importantly, you want to have all the materials that you need. There are quite a few materials associated with this program. So this is a list of the materials, and we're going to talk more as we talk about the procedures about how you use each of these things. But you're going to want to have lots and lots of underwear. Again, the child is going to be out of diapers or pull-ups and in underwear, so you want to make sure you have enough to get through a couple of days. And if you don't have enough, or if you know that you're going to need to do laundry, you want to make sure that you have access to laundry. And that you have, your laundry detergent stocked up, or if you live in an apartment building and you don't have laundry in your apartment, that you have ready access to the laundry facility. If you don't have access to laundry facilities, then you probably want to do everything you can to make sure you have enough underwear to last for at least 2 days. It is okay to have pull-ups, but these are going to be for nighttime or naps only, not for wearing during the day. But you don't necessarily want to get rid of all your pull-ups when you bring the underwear on board, because you may still want those at night or during naps. You want to make sure that the toilet is accessible, and that if you need a potty seat, if you need a step stool, whatever you need to do to make the toilet comfortable, that you have those supplies. You want to make sure that you have highly preferred rewards. Highly, highly, highly preferred. I cannot emphasize this point enough. These should be the rewards that the child will do anything for. This is oftentimes food rewards or treats, which is counterintuitive for some people because we are going to have these things available in the bathroom. But you want the rewards to be the most incentivizing thing you can think of, because you're going to be engaging in this process intensively for a couple of days. You want the child to maintain their motivation. It's also really good to have a variety of rewards if you can, which is hard for some kids with autism because they're hard to motivate. They oftentimes only have one or two things they like. But to the extent that you can have variety, that also helps to make sure that the rewards don't lose their salience or kind of wear out, so to speak, and, where kids are no longer motivated by them because they've satiated. We want to have preferred liquids available. So in order to keep the child drinking as much as we want them to drink over the course of a couple days, you probably are going to have to also have a variety of liquids, and they're going to need to be things that are preferred. Sometimes these are not the healthiest liquids or the things that we prefer to give kids, but given that we're only going to be doing it for a couple of days up front, it can be really worth it to be sort of more lenient on what some of your rules around things like juice or sugary drinks that we might not normally want kids to have. Watering things down is helpful because it keeps kids from satiating and getting tired of drinking the same thing. It also obviously cuts down on things like sugar and ensures that the child is getting enough liquid in the process. Salty snacks can also be useful. Again, it probably doesn't sound too healthy. It's not the ideal diet, But salty snacks are going to offset the liquid that the child is drinking and are going to potentially motivate the child to keep drinking. So again, it's not necessarily ideal in terms of the kind of diet that we want to see the child have all the time, but given that it's only for a couple of days, it can oftentimes really be worth it to attain the goal of toilet training. We want to have data sheets available, and I'll show a data sheet down the road in a few slides and also talk about how to use it. But taking data is really, really, really critical for tracking your procedures and also demonstrating success of the procedures. It can oftentimes be helpful to have an outline of the program instructions. So there is an outline in the manual that is listed at the end of these slides. Parents have oftentimes also made their own outlines, bullet pointed lists, just little key reminders, something you can put up on your fridge and give to the teachers at school, or have the child bring in their backpack or their bag to therapy so everybody can remember what needs to happen. Just like underwear, you want to make sure you have plenty of clothing. If the child is having accidents, they're also going to be having wet clothing. Some people like to use a pants alarm, and I'll just talk about this for a second. There are a variety of products available that are alarms that you can attach to the child's pants, and as soon as they start urinating, the presence of liquid completes a circuit and causes an alarm to go off. Some people find this helpful for monitoring accidents. The caution that I usually, sort of use with kids with autism is sometimes when kids have sensory issues, and especially auditory sensitivity, or when they're sensitive to unexpected noises or unexpected events or being surprised, sometimes the pants alarm is not the best idea because you certainly don't want to condition sort of a fear response every time the child starts urinating. Kids with autism are notorious for withholding their urine, as notorious as they are for holding their bowel movements, and we don't want them to be in a situation where they think that urinating is going to cause, an alarming stimulus to go off, and then where they start trying to hold their urine. So the pants alarm is used with caution, but some families do find it helpful. Items to prevent a mess in your house. So because the child is going to be in underwear, it's really, really important to be aware of the ways in which that might be stressful, for a parent or for a family. So thinking about what needs to happen to sort of mess-proof the home so that the couple days spent in underwear is not going to be really, really stressful. So do we need to cover up couches? Do we need to roll up rugs? Do we need to buy mattress covers? Do we need to stay out of certain rooms? Maybe you stay out of the formal living room because that couch is, the pristine and beautiful couch that you don't want a urine accident on. But we really want to think about that ahead of time because it can be really stressful for families to think about having to clean urine off of rugs and furniture. And if you're already going to be busy enough during this weekend, we don't want to have that be an additional stressor. And then sometimes visual cues, and we'll talk a little bit more about where and how visual cues can be useful. But if we're going to be using visual cues, we want those prepared ahead of time. So a little bit more on the preparation, preparing the environment. A comfortable toilet seat or potty chair is really key. And I think most people can relate to the idea that it's not very easy to void when you are not relaxed. So if you think about what it's like, for women, if you think about what it's like to use a public restroom when you're trying not to sit on the toilet seat, it's not that easy to release your urine in that situation. And the very same is true for kids. If they're not comfortable on the toilet, it's not going to be that easy for them to release their urine. So we want to think about what we need to do to make them comfortable. So on this slide are 3 examples of products. One is a freestanding potty chair, which everyone is usually familiar with. One is an insert that sits on top of the toilet. That's the pink one in the middle. And then one is actually a toilet seat that you can replace your existing toilet seat with that has a child-sized seat attached to it. This is one that sometimes families are not familiar with. You completely change out the toilet seat on your toilet with this one, and then you can flip up the child's seat when an adult needs to use the toilet and flip down the seat when a child needs to use the toilet. So this can be a nice option. One thing I will say about the use of potty chairs is if you can avoid it, it's better. If you can start by training the child on the big toilet, what you're going to essentially do is eliminate a step later on of having to transition the child from the potty chair to the big toilet because they're not going to be able to use the potty chair forever. And of course, what we know about kids with autism is that they can have a hard time changing routines or making those kinds of transitions. So if you can avoid that up front by just teaching the child how to sit on the big toilet using potty seat, inserts or the special potty chair that you can install, or the special potty seat that you can install, you're going to be better off because you're going to skip that step or avoid that step of having to transition them to the big toilet from the potty chair. Now, that being said, some kids are already really rigidly using a potty chair when we start toilet training, and so sometimes it can be better to just start the toilet training process using what they're already doing and make that transition later. We also want to have access to any stools that we might need to make sure that kids can comfortably get up on the toilet. Oftentimes, kids are more comfortable if they can rest their feet on a stool. Dangling feet aren't always that relaxing. A stool to access the sink might be another one if the child is going to be practicing washing their hands after, and anything else you need to make the environment comfortable. So thinking about all aspects of sensory concern that you might have for a child would be really important. Are the lights too bright? Is the sound of the flusher too loud? Is the bathroom really echoey? Would it be helpful to get a rug in there to decrease echo, that kind of thing? Whatever might be helpful in supporting the child. So when we are thinking about what to wear, I mentioned that we are going to want to put kids in underwear. And the reason for this is that the child needs to feel the sensation of being soiled. If they have an accident, they need to know they've had an accident. And diapers and pull-ups work too well, right? I mean, parents of young kids certainly know this. When you take off a wet diaper, unless it's really, really, really filled with fluid, your child's skin is not actually that wet because all of that gel or whatever it is that's in the diaper has absorbed all the liquid. And while that's helpful for kids who are in diapers because it does things like prevent diaper rash, it's not helpful for kids who are learning potty training because they don't feel the associated sensation of being wet. By the same token, we also don't want to let kids remain in soiled pants. So even when they're in underwear, we don't want to let them sit in wet underwear because they're going to get used to that feeling and they're going to lose the sensation of being soiled. We want kids to have a stark experience of when I wet or when I have an accident, I'm very wet. And when I'm dry, it's a very different feeling. We want that to be really distinct. Training underpants are okay. So what I mean by training underpants are thick underwear that have sort of an extra layer of padding that absorbs, but they're not pull-ups. I do not mean disposable pull-ups. Those are two different products, and I think most people know the distinction. Plastic pants can be worn on top of the underwear. If you're concerned about a mess, that's fine because, again, the underwear is still next to the child's skin, and they will still have the sensation of being wet. I will say that plastic pants don't necessarily control the mess as much as you think they will. A full, void of the bladder is going to overflow plastic pants. And I have had some parents tell me that it's actually worse because then when you pull the plastic pants down, you get sort of this giant, dump of fluid, and it's really hard to control it. It's not like you can very easily dump it into the toilet. And so, some parents feel like it's actually not that helpful. But it's up to each family. Pull-ups at night are okay. So most kids who are learning toilet training during the day don't learn toilet training at night right away. They will oftentimes stay wet at night for a while longer, and that's fine, and it's normal. So we want to put on the pull-ups right before bedtime. We don't want the child to have the opportunity to run around the house, to play, to engage in evening routines while wearing a pull-up. So it might require some revamping of the bedtime routine. Oftentimes, kids will put on their jammies and then maybe they'll play for a while or watch a show. But what you don't want is for them to have that opportunity to urinate in the pull-up while they're still awake because, again, then they're not going to have that sensation of being wet, and that's confusing for their learning. So putting it on right before they get in bed is the best thing to do, and then taking it off immediately when they wake up. So same thing. You don't want them waking up in the morning, hanging around in their pajamas, having an opportunity to pee in the pull-up. You want them to get up, take the pull-up off immediately, and the first thing they should do is go to the bathroom to see if they can void in the toilet. So that way, hopefully, if they're peeing in the pull-up, it's while they're asleep, which is not going to sabotage their learning the same way that peeing in the pull-up while they're awake might. And then we want them to have easy access pants. So we don't want to have buttons, snaps, zippers, especially we don't want belts or tights on girls. these are all really, really hard for kids to navigate, right? So we basically want like sweatpants or leggings that are easy down, easy up, quick access, so that that's not a barrier to successful training. So the procedures of habit training themselves are listed on this slide. So the first thing that we want to do, and I'm going to go into each one of these procedures in detail, is put the child on a schedule and provide them with frequent opportunities for scheduled toileting. So this is usually 1 to 2 times per hour while we're engaging in habit training. Then we want to prompt them to make a potty request, and even if they don't know how to communicate well yet, or even if they don't know how to evaluate whether they actually need to go to the bathroom, we want to start prompting them to use the communication that would be necessary so that they're learning how to use it in that context, with the idea that down the road they might start to do so spontaneously. And we'll talk a little bit more about that. We want to remove all obstacles to self-initiation. So once you start, you don't want your bathroom to have a baby gate on it. You don't want the child to be stuck inside of a room where they can't get access to the bathroom because there's a baby gate on the hall, or because the door is closed, or because they have to go upstairs. You want the child to be able to initiate if they have the desire to do so, because that obviously is the end goal. We're going to schedule frequent dry pants checks, which we'll talk more about what those are. We're going to reward all successful voiding in the toilet. We're not rewarding going in the bathroom. We're rewarding voiding in the toilet, and we'll talk more about that. We are going to engage in a procedure called positive practice for accidents anytime an accident occurs, and this is a teaching procedure, sort of a corrective procedure, but not meant to be a punishment. And then finally, we're going to take data on a data sheet. So we'll go through each one of these procedures in detail. So the first one is scheduled toileting. We want to increase the likelihood of successful voiding in the toilet. So the way to do that is to provide frequent opportunities for practice, frequent opportunities for going to the toilet. So while you're doing habit training, remember, we're going to be giving the child as much fluid as possible. We want to be pushing fluids constantly throughout this process. And so the child is probably going to have to go to the bathroom pretty often. So we want to take them to the toilet at least 1 to 2 times per hour. And when you're first starting out, the first few hours that you're training, it can be a little bit hard to figure out exactly what the schedule should look like. How often should you actually be taking them? And the best way to figure it out is to take your data within the first couple hours, and you're going to be taking data on both voiding in the toilet and accidents, because then you can see how often does the child need to pee. And then you can take them on a schedule that is just a little bit more often than that. So what I mean by that is, like, if you can see from your data that they need to go to the toilet, or that they are voiding every 25 minutes on average, then you probably want to take them about every 20 minutes, a little sooner than you think they actually have to void. Because what you're trying to do with this schedule is you're trying to create probability that when they void, they'll be sitting on the toilet. Because the idea is that they don't understand what the expectation is yet, right? You've just started this process. They don't know what the goal is. If they're a child with very significant delays, you can't explain to them what the goal is. So you have to teach them by showing them. And the only way to do that is to create probability that they are sitting on the toilet at the time that they do actually end up voiding, and then you can reinforce that behavior by giving them a reward when they're in the bathroom when they've just voided. So we want to really try to catch them when they have to urinate by putting them on the toilet. And remember, the frequency is increased by providing them with increased fluid intake and also then salty foods to perpetuate that. And I usually recommend to families that they push fluid pretty much constantly. If you're attending to the child in the way that you need to be to engage in this process, you're going to be with them pretty much constantly. And you can be just handing them, their sippy cup or their water bottle or whatever it is every couple minutes. And even if they only take 1 sip, just keep handing it to them. Just keep pushing that fluid. Because they will satiate after a while, and they will, start losing interest in being willing to drink. But the frequency with which they have to void is one of the keys to the success of this program, because it creates that increased practice. And so we don't want to be in a situation where a child isn't drinking any fluid and then doesn't have to urinate for like 3 hours, let's say. You really lose a lot of opportunities during a time like that for practice. And then it's good to always take the child after they eat or drink any substantial amount. So just make a habit out of, after each meal, after each snack, after they drink a glass of something, take them and sit them on the toilet. Again, you're trying to catch them at a time when they need to void so that you can reward them for voiding in the toilet, even if it's a complete coincidence. So when you take the child to the toilet, you want to have a consistent adult verbal prompt. So we want to use the same words each time. Again, for kids with communication and language delays, there's no guarantee that at the beginning of this program they have any idea what these words mean. These may not be words that they understand the meaning of, but they are going to come to understand the meaning through repeated practice. And so if we want them to understand that and learn those words, we need to use the same words every time. If we use different words every time, it's going to potentially be confusing, especially for kids who have significant communication delays. And then you want to try to prompt them to either say or indicate in some way, so using a picture card or using a sign if they're nonverbal, that they have to go potty. And even if they aren't aware that they have to go potty, even if they're trying to tell you that they don't have to go potty, you're trying to build that communication step into the routine. So you might literally have to say to them, it's time to go potty. Tell mommy, potty. And they just repeat potty, and it may feel totally rote and meaningless the first number of times, but you're programming or sort of laying the groundwork for the communication behaviors that you hope they use later. So as soon as they engage in that behavior, whether it's verbal or nonverbal, then you respond to them as if they've communicated to you. So you will say to them something like, yes, good, you have to go potty, let's go. And off you're going to go for your trip to the toilet. If the child makes any kind of initiation at all, whether it's to ask, whether it's to take you by the hand, whether it's to give you a card or use a sign, you want to take them immediately. It does not matter when the last time was that you took them or when the last time was that they initiated. It doesn't matter if they initiate with you every 5 minutes during the training process. You want to reward that behavior because ultimately initiation is the behavior that they need to engage in order to independently be toilet trained. So we don't ever want to discourage that behavior. Later on, once they're better trained, if they're initiated too often, we can use some interventions to decrease that. But while kids are being trained, we want to encourage them to engage in any initiation behavior that they can. And again, we want to minimize any obstacles to self-initiation. So the next step then is rewarding any successful voiding in the toilet. So this can be any amount. Parents will ask me, well, how do you define how much is a successful void? Anything. And the tiniest trickle, the tiniest little part of a bowel movement, as long as you're sure that it happened. Because the child doesn't have an understanding of, did I void a little? Did I void a lot? Was that a full void of my bladder? Was that a full bowel movement? They don't have any understanding of that. What we need them to understand is you're supposed to void in the toilet, so we don't care how much it is. If they void at all, you want to engage in both social praise and also some kind of a tangible reinforcer. So it's oftentimes a food snack. It can also be some kind of an activity reward like 5 minutes of iPad or their favorite toy or book. But you want it to be something that they don't have access to at any other time of day. It's not going to function as enough of a reward if it's the same iPad that they get, when they leave the bathroom because now they're, allowed to choose what activity they're going to do next. It has to be something that is reserved only for use as a reward for voiding in the toilet. And it has to be something that you can give immediately. So again, especially for kids who are very delayed in their learning, that reinforcement can't be delayed. It has to happen literally almost while they're voiding or the second they're done. So if you're going to use food snacks, you have to be willing to keep them in the bathroom, and you want to have a plan for that. Where are you going to store things? How are you going to store them? If it's an activity reward, how much time with that thing do they get? How and when do you cut them off or prompt them that they're all done? But you want it to be really, really motivating and something you can give right away. You want to remember that the rewards are defined by the child, not the adult, so it needs to be something that they find to be desirable and that they're excited about. And again, the rewards need to be immediate, so happening right there in the bathroom. The rewards need to be contingent, meaning You give the reward every single time if any kind of voiding happens, and you do not give the reward if the voiding doesn't happen. So although they might have done a really good job coming in and sitting on the toilet, you can't give them that reward unless they voided, because they're not going to learn what the expected behavior is. You can do other things to make being in the bathroom fun. While you're in there and while they're sitting, you can sing songs or read books, or you can, look at a phone or an iPad, as long as those things are not being used as a reward for voiding. The activities to make being in the bathroom fun have to be separate from the activities or the rewards that you use for when they voided the toilet. And then you want to really heavily emphasize the reward. So if there is a success, you want to make sure cheering, clapping, whatever you know is rewarding for the child, you want to make sure that they know that was the desired behavior. That's how they're going to learn that that's the expectation. Dry pants check is just what it sounds like. It's a very straightforward procedure. It's a procedure that we do in between your trips to the toilet. So while you're waiting for your intervals, which are probably maybe 20 to 30 minutes in between trips to the toilet, you partway through that want to check the child's pants. So all you do is you literally just draw attention to the fact that they're dry. And you're trying to teach them the difference between accidents and continence. So, you can take their hand and just encourage them to kind of pat their hips or their crotch or their buttocks and let them know, using, again, specific language, that they are dry and that that's a good thing. Good job, you're dry. Good, your underwear is dry. You're staying dry. You, again, want to use consistent language, because initially they may not understand what that means, but we hope that they come to understand it during the process. Then you can reward them for being dry, either with social praise or other tangible rewards, but you don't want to use the same rewards as the ones you're using for voiding in the toilet. You want to save the most desirable rewards for when they actually urinate or have a bowel movement in the toilet. And if you're going to use rewards for dry pants checks, you want them to be like their second choice reward, not their first choice reward. In behavioral terms, we call that differential reinforcement, which means that a behavior that is harder, that we're trying to teach, gets a higher level of reinforcement, and a behavior that is a little bit easier or a little bit lower priority gets a slightly lower level of reinforcement. So you can use a differential reinforcement strategy for dry pants checks. And then you can use a pants alarm like we mentioned, although you don't have to. And most people, I would say, don't use a pants alarm. Positive practice for accidents. This is a point that is so important. I cannot emphasize positive practice enough. This is the way that we teach kids that accidents are not the desired behavior. So positive practice has to happen immediately upon discovering an accident, which is part of why an adult needs to be really closely monitoring the child. Somebody needs to be there and be aware as soon as the child starts voiding, anywhere other than in the toilet, because you want to initiate this procedure instantly, even sometimes while they're still voiding. Just like how reinforcement needs to be really immediate, this needs to be really immediate. So as soon as we notice that an accident has happened or is happening, we want to initiate the positive practice procedure. I encourage families to use a firm, calm, neutral voice. Some places in the literature, and the manual that I recommend at the end is one of them, some places in the literature, people recommend that you use more of a reprimand, like you sternly say no, and that the child sort of understands that they're in trouble. I actually don't think that's helpful. I actually think that it interferes with learning because it's usually upsetting for kids, and we're trying to engage them in positive practice as a teaching procedure. And if we upset them by reprimanding them right off the bat, it doesn't create the best learning climate for the child. And I think most parents can relate to that. When your child is crying, it's not the most teachable moment. So I think it's better to use a firm, calm, neutral voice and just think of it as a teaching opportunity. It's not a situation where the child is in trouble. So you can firmly say something like, no, you wet your pants, or no, you went potty on the floor. Whatever, again, is going to be terminology that you can consistently use and that the child is going to understand. And you want to label the behavior that was incorrect. No, you wet your pants. Tells them what they did that was not correct. Then you immediately want to take the child to the toilet. You want to help them change their pants while you're in there. So you're going to need to have changes of clothes or changes of underwear in the bathroom, because then you want to engage in the practice procedure immediately following. So you can say to the child something like, you wet your pants, now we have to practice. And the practice consists of proceeding through the entire toileting sequence 3 to 5 times. And some people recommend this more than 5 times. Again, I don't necessarily find that to be very helpful because I think it gets pretty aversive. And this is not meant to be a punishment per se. It's not meant to be something that's negative for the child. It's really meant to be more like a correction. Like in behavioral terms, sometimes people call it overcorrection, meaning that you're engaging the child in repetitions of the behavior that they should have done. So what you're going to do is once you've taken them to the toilet, taken off the wet stuff, put on the dry stuff, you're going to go back to where the accident happened, scene of the crime, so to speak, and repeat the process. So let's say the accident happened in the living room. You're going to go back to the living room to exactly the place where it happened. If there's a wet spot on the floor, you can even reference the wet spot. And you're going to say to the child something like, we don't go to the bathroom or we don't go potty in the living room. We go potty in the toilet. Let's go practice again. You go back into the bathroom. You pull down the pants. You sit on the toilet, maybe for 5 seconds, 10 seconds, a short period of time. Pull up their pants. Go back to where the accident happened. Repeat the steps, the same thing. We don't go potty in the living room. We go potty in the toilet. Go back to the toilet, pull down the pants, sit on the toilet, pull up the pants, so on and so forth. I usually recommend that parents skip the hand washing routine while they're doing positive practice until you've done the final practice. Then you can wash hands once at the end. But the point is not to belabor the whole entire routine like that. The point is to belabor the fact that they should have gone pee in the toilet. So the goal here is repetition. Oftentimes families will say, there's no way I'm going to get my kid to do this 5 times. Or once they've done it, they'll say, he started crying immediately on the first practice. There's no way I could drag him through 5, repetitions of that. And your goal is repetition. So 1 time is not enough. You need to at least get to 2. But I usually recommend that as a bare minimum, families aim for 3. Because again, you're trying to overcorrect. You're not just trying to give the child the message that this is what they should have done by having them sit on the toilet once. So if you can get to 3, I think you're doing good. If you can get to 5, you've really met the goal, but you really want to do it more than once. And if kids have tantrums, in response to this, the best thing to try to do is to motor them through the tantrum, because once they realize that you're not going to let them off the hook after several trials, they're most likely going to stop resisting or stop tantruming, and you're going to be more successful over the course of a couple of days. And then you can resume your scheduled toileting. So when I say resume your scheduled toileting, what I mean is then you can go back to your intervals. So, you will have recorded that the child had an accident, and you can say, okay, now we can probably wait about another 20 minutes before we need to go to the toilet again because they just voided. Taking data. Taking data is really, really important. You want to take data immediately after each event or procedure related to toileting. And you want to have the data sheets really, really available during this process, because it's going to be really hard to run all over the house looking for them when you're trying to record certain things. What you want to record is the date, the time, and the place of each event, whether it was a success or an accident. So if the child voided, you definitely want to be recording that they voided in the toilet or they had an accident, because that's going to tell you 2 things. One is, how often are they actually urinating? How frequent is it? And so you can adjust your intervals of your schedule accordingly. But it's also going to tell you how successful they're being. If over the course of a day, their successes in the toilet are going up and their accidents are going down, that's going to tell you that you're making progress. And if you don't have those data, trust me when I say, you're not going to think you're being successful. You're going to feel like you've had a ton of accidents over the course of a day, and you're not going to think it's successful. But what I usually recommend that families do is that you break your day up into 3-hour chunks, and then you look and see in each 3-hour chunk how many successes and how many accidents did we have. Because what you're going to find is that over the course of the day, success is going up and accidents are going down. So I'll give you an example. You might say that the child wakes up at 7 o'clock in the morning. So So your first 3-hour interval is going to be 7 to 10. Then your second 3-hour interval is going to be, 10 to 1, then 1 to 4, then 4 to 7. And when you look at each of those 3-hour intervals, you're going to say, how many accidents did the child have between 7 a.m. and 10 a.m.? How many successes did they have? Well, the first day, probably it's going to be mostly accidents and very few successes between 7 a.m. and 10 a.m. But between 10 and 1, when they've been learning for somewhere between 3 and 6 hours, you're probably going to find a few more successes and a few less accidents. And then between 1 and 4, even more, a few more successes and a few less accidents. And you're going to want to be able to look at those data to see that you're making progress. Because when you look at the whole day, let's say the child is up from 7 a.m. to 7 p.m., when you look at the whole day, you're going to feel like we had a ton of accidents, and you're not going to have a sense for what the progress actually is unless you look at the numbers. You also want to make note of the type of voiding, so did they urinate or have a bowel movement. You want to note if it was scheduled, meaning that an adult prompted it and initiated it, or whether the child initiated it, because you certainly want to know how often they're initiating if that's happening. And then you want to know that you went to the toilet even if no voiding occurred. There's going to be so much going on that sometimes it gets hard to keep track of your time interval. Like, what time did we last finally, what time did we last go to the toilet? And when you start to try to remember, sometimes it can be hard. So if you look at your data sheet and you say, okay, we last went to the toilet at 10 o'clock, it's 10:25, we should probably go again. So it's as much about tracking that you're doing the procedures correctly as it is about tracking what the child's behaviors are. And a lot of parents also like to track whether they did dry pants checks or not and how many times they did positive practice, because then you can really see for yourself that you're doing all the procedures correctly. You can also, like I said before, then use these data to dictate the toileting schedule within the first few hours of your increased fluid intake. So, this is not the normal situation for your child, right? You don't normally give them all this fluid, and they don't normally have to pee this frequently. So sometimes it can be hard to gauge how often you need to take them to the toilet. But if you look at your data after about 3 hours and sort of average out how often are they actually urinating, you can adjust your schedule accordingly, both to make sure that you're not taking them too often, because there's no reason to be placing extra demands and doing extra work, but also to make sure you're taking them often enough to make sure that you're not taking them, just a little too late, and then they're having accidents as a result of that. So here is an example data sheet, and I want to make sure we give credit to where the data sheet came from. This is from a manual by Dunlap, Kegel, and Kegel, and the full citation is at the end of these slides. This data sheet in this manual is meant for reproduction, so it states specifically in the manual that you can copy it and use it in order to implement these procedures. And I find this to be a really helpful data sheet because it has on it pretty much everything we want to track. You can see across the top it has place, date, time. Then if it was an accident, you can record whether it was urine or bowel accident. If an adult took the child to the toilet, you can record whether they urinated, had a bowel movement, or did nothing. And if the child self-initiated, you can record whether they urinated or had a bowel movement. So then this data sheet, once you look at it all together, really gives you information about how often is the adult taking the child, how often is the child actually urinating, and how much of the time is that an accident versus a success in the toilet, which is how we're going to track the progress. So I think this is a useful data sheet. Now, I've done toilet training with tons and tons of families, and some families don't find this data sheet to be intuitive enough. Some families want to set it up a different way, and that's fine. However it makes the most sense to a family is fine, and the most important thing is that the data are being collected. So whatever the most effective way is to do that is great. Again, the intensive kind of procedures with the increased fluid intake for 2 to 3 days. What you're going to do when you're done with that is resume your normal fluid intake and a more normal toileting schedule. So a more normal toileting schedule is usually something like every 60 to 90 minutes. And if you've taken data before you started, hopefully you have some idea of how often the child urinates under normal conditions, and that's the schedule that you want to put them on. And usually it's a schedule that's, number one, pretty doable. Every 60 to 90 minutes, most people don't find to be too labor-intensive or too hard to do. And also, it's pretty much consistent with the schedule of what you would do with a typically developing child who was early on in their toilet training. All kids need a lot of prompting and reminders when they're just toilet training. And people in early child care settings and preschool teachers, therapists who work with young kids, they're usually used to the fact that kids need to be prompted about every 60 to 90 minutes. It's also a schedule that fits nicely into preschool, for example. No preschool routine is set up in such a way that the kids are continuously doing the same thing for 90 minutes and can't be interrupted, right? So the schedule can usually be worked into kind of the natural routine. The trip to the bathroom can usually come at sort of natural transition points, but it requires sort of thinking about what that's going to look like and when those trips to the bathroom are going to happen. Like we talked about, you want to coordinate that across settings. And the goal of the first 2 days is, again, to establish contact. You want the child not to void until they're taken to the toilet. They may not learn to initiate, but they should learn, hopefully, how to hold it, and their frequency of accidents should go down a lot over the course of the first 2 to 3 days. And then you want to continue the toileting schedule, the more spaced out schedule, the every 60 to 90 minutes, until the child begins to initiate or communicating that they need to go. Or in the case of some kids who don't really learn to initiate or communicate very well, you want to just establish what that schedule needs to be in order to prevent them from having accidents, and then just continue it. So what I usually recommend is that all procedures be continued. So after the first day, or a couple days, I should say, you're going to continue all the procedures but back off on the intensity. So I think that all procedures should be continued until the child is having less than one accident per week. So the procedures that should continue after the upfront 2 to 3 day intensive training are the toileting schedule, the reinforcement for voiding in the toilet, the positive practice for accidents, and the dry pants check. And those should continue until the child is really having very few accidents. Sometimes that goes on for a while. I've had families that I've worked with where that has gone on for a number of months. But it becomes pretty doable because, again, the prompting for the schedule is not that often. The reinforcement is usually a well-oiled machine by that point. It's in the bathroom. The family knows what it needs to look like. The positive practice is hopefully not happening that often if you're not having that many accidents. And the dry pants checks are pretty easy and quick to conduct. So usually these procedures are pretty sustainable if they need to be. Families will also often come in and say, we had it down for a while, the child was doing really well, but then a regression happened. A school break came, or a vacation, or the family moved, and suddenly the child regresses. If that happens, I recommend that all procedures be resumed. So all the procedures that are listed above on this slide, and especially the positive practice. I cannot emphasize how often families come in and tell me that either a regression has happened or that the child is still having accidents. And when the first thing I ask is, are you doing the positive practice, they say no. And I think that's really, really crucial to ongoing success. Then once a child is being successful, families will often express concern about the reinforcement. Like, do I have to give my kid M&Ms every time he pees for the rest of his life? And the answer is no. If the child is not having accidents, and if they're successfully voiding in the toilet, you can start to fade those reinforcements. Give them less and less often and put less and less emphasis on them. But oftentimes the reinforcers fade naturally. Oftentimes the families will come in and say things like, it's not working. The child doesn't want the reinforcer anymore. And I'll say to them, is the child having accidents? Is the child still urinating in the toilet? And if the answer is yes, then it doesn't matter that they don't want the reinforcer anymore because the learning has occurred. It only matters if the child is not successful voiding in the toilet, and then it means we usually need to find new reinforcement. But reinforcement oftentimes fades itself naturally over time. So a couple more words on coordination. When we're trying to coordinate across settings, we want to make sure that we have one person, usually it's a parent, who is kind of the one who is going to communicate with everybody in all the different settings, and the person who's tracking the progress so that the people in the different settings can have information if the procedures need to change at all. We need to make sure we know what settings those are: school, home, therapy, child care, mom's house, dad's house, grandma's house, whoever it might be. Um, we want to make sure that we communicate across those settings like we talked about. And it can oftentimes be a good idea to have an initial meeting before you start the habit training, where everybody kind of comes together and you really make a plan for who's going to be responsible for taking data, who's going to be responsible for communicating back to the coordinator if there's a problem in any given setting, how is data going to be shared among the settings, who is going to be responsible for the procedures, and when are we starting, so everybody's on the same page. And then, like we mentioned, during habit training, during the 2 to 3 days, we want to ensure that somebody is with the child during all their waking hours. But once it's done, we want to maintain that coordination over time until the child's not having any more access. Teaching communication is something that I like to touch on for just a minute. So, like I mentioned, when we prompt the child to use the toilet, one of the things that we want to do is start to kind of lay the foundation for communication behavior. Because, of course, they're not going to learn how to say they need to use the toilet if we don't teach them or at least model appropriate behaviors for that. So first we want to think about what the communication behavior is going to be. For kids who are verbal, it can be saying a word or a phrase. It can be saying potty or I need to go potty or go potty or toilet or whatever the family deems is most appropriate for the child. For kids who are not verbal or who are less verbal, we might need alternative or augmentative forms of communication. So sometimes people will use an object like a little toy or something that represents the toileting process. Oftentimes people will use picture exchange cards. For kids who can read, oftentimes people will use printed words like potty. There's an example of a picture exchange card on this slide. And then we want to reinforce all attempts at communicating that the child engages in. And early on in this training process, we want to reinforce even behaviors that are not the most appropriate communication behavior. So an example of that is, let's say you're trying to teach the child how to use a picture card, but they pop out of their chair and grab you by the hand. Well, that is a communication behavior. And although it's not the one we're trying to teach, we want to reinforce them for any communication behavior they can engage in, particularly because it's going to increase the likelihood that they successfully avoid in the toilet if we follow their cues. So it's early on, it can be good to follow any cue like that, and later on we can try to teach kids more clear and appropriate communication behavior. We also want to make sure that the communication strategy is available at all times. So for kids who are verbal, obviously they have their words available to them. For kids who are less verbal or not verbal, and if we're using any kind of a visual cue, we want to make sure that those things are available. So I'll encourage families to put the visual cue up all over the house. Set it in different places or Velcro it to the wall in every room. Make it really available. Don't make the child travel very far to have access to that cue. Because it also serves as a reminder. Oh, yeah, I can go get that picture and let someone know I need to go potty. We also want to make sure that it's available outside the home. So at school, same thing. We want it readily available. In public, I'll oftentimes say to families, that it can be a good idea to, attach it to a little ring and put it on the outside of your purse or on the outside of the child's backpack, or so that again they can access it. Sometimes people will use those retracting cords that like people have their office ID badges on sometimes, and you can clip that on things, and then the child can sort of like pull out the cord to be able to show the card. Whatever's going to be convenient, accessible, and easy. Also thinking about what's going to be discreet, especially for older kids. I mean, obviously we want them to be able to communicate, but we also want to be respectful of their privacy and those kinds of things. So just thinking about appropriateness and kind of discreetness. Teaching initiation is often a question. So again, we want to be laying the foundation for that by having the child communicate potty before we take them, before we engage in the routine. We want to provide really easy forms of communication. So again, like we just talked about, visual cues, and even sometimes for verbal kids, visual cues can be helpful. If nothing else, it serves as a reminder. We want to reinforce any attempts at communicating, like I talked about. And one of the things that you can start to do early on is encourage independence with the routine during any steps the child can do themselves. So even if the only thing that they know how to do is pull up their pants or pull down their pants or get up on the toilet on their own, have them engage in whatever steps they're capable of independently so that you can foster more and more independence over time. If the child can go independently, and if they do, don't require them to ask. So sometimes parents will say, well, he ran into the bathroom and he went, but he didn't tell me. Well, that's fine. That's what typical kids do, right? So if the child goes on their own, we certainly don't want to stop them and make them ask. We want them to be able to ask, so we might need to work on that at other times of day, but we don't want to interfere if they're trying to go on their own. And then the last thing that we can do is, again, we can use that differential reinforcement like we talked about before. So once a child is well trained and they're voiding in the toilet consistently and not having accidents, what you can do is you can change how you use the reinforcers. And you can make those most highly desirable reinforcers, the number one, favorite thing of the child, as the reinforcer for initiating using the toilet, and less powerful or less desirable reinforcers as the ones that you give them for actually avoiding in the toilet. So you make initiation the new sort of like highest level of behavior that you're rewarding, and you match that with the highest level of reinforcement, and you make voiding in the toilet be a little bit lower level of reward, assuming that it's something that they've now really mastered. You don't want to go to that differential reinforcement if the child has not already mastered voiding in the toilet really consistently, though. This is only like a very last step once they're very, very good at voiding in the toilet. So some helpful hints, and then we're going to talk about troubleshooting for a few minutes before we wrap up. Some helpful hints about habit training. I mentioned this already, but I don't think it's helpful to reprimand the child for accidents. I think it's most useful to just remain neutral and think of yourself as a teacher in that situation. With regard to the positive practice, the more times you do it, the better. But my experience, especially with young kids, is that they'll comply with 2 or 3 repetitions before they start getting a little resistant or avoidant, and I think that's enough. What is not enough is 1 or none. So if the child is having tantrums, it's really important not to stop and to try to get them through at least 2, but preferably 3 repetitions. Most often, I find it to be helpful to avoid sitting in the bathroom for long periods of time. People have oftentimes heard of toilet training programs where you just stay in the bathroom for hours and wait for the child to pee so that you can reward it. For some kids that does work, and if you want to try that, I don't think that's a bad thing. But for some kids, it builds a lot of resistance and avoidance because they think then that when you prompt them to enter the bathroom, essentially, they're not going to be allowed out for like hours on end. And for some kids, that's pretty aversive. So I think instead it can be helpful to go in the bathroom, sit for 2 or 3 minutes, long enough that they can relax and hopefully void, and then leave and return soon if you know that the risk is high that they're going to void. So, if you know that it's been a half an hour since they last voided and you're right in the middle of your intensive habit training and you think to yourself, they must have to pee, or urinate pretty quickly here. I don't really want to wait another half an hour. You're probably right. You probably shouldn't wait another half an hour. You should probably go back quite a bit sooner. But you don't have to just sit in there. You can leave and come back 2 minutes later or 5 minutes later and just keep kind of repeating that rather than just sitting there. But you do definitely want to use your common sense and try to predict when they're next going to void. That schedule that you are using is not meant to be hard and fast. And the more time that goes by, the higher the probability is that they're going to have to void. So if you know that it's been, like I said, a half an hour or an hour, you probably don't want to wait another whole interval, another whole 20 or 30 minutes. You probably want to go back about 5 minutes later and about 5 minutes after that until finally they do void. So you want to adjust your time intervals according to when they last voided and how well you think you can predict when they're next going to need to void. Like I mentioned before, it's fine to make time spent in the bathroom fun. You can provide preferred activities. You can, sing songs, whatever you need to do. And then do whatever you need to do once the intensive training is complete to make them successful outside the home. Some parents I know have carried a potty chair in the car. You can do that on the side of the road if you need to, right? So you want to really do whatever you can do to make that training successful across settings. I've definitely also had parents just carry the potty seat insert. They'll come in with the child's backpack and the toilet seat is like strapped to the outside. Again, whatever you need to do to make that training successful. So some common problems, some troubleshooting. One problem is lack of generalization to new locations. So a couple of possible solutions or strategies that might be helpful. One is I oftentimes encourage parents plan practice in other settings. So, for example, go to the grocery store at a time when you don't really actually need to do a lot of grocery shopping, and go to the bathroom on purpose in order to practice in that setting and reward the child if they do. Or every time you go to therapy, even if they don't need to use the toilet, have them just go sit and practice so that they can practice using the toilet in that setting, and again, reward them when they do. So oftentimes just practicing in new settings on purpose. If you go to someone's house, again, even if you don't think they have to go try to go in that person's house. Go over to your neighbors on purpose just to practice, whatever it might be, but really trying to seek those opportunities. You can get a lot of those trials in. Carrying reinforcers with you can be really helpful for the same reason, and you can reinforce kids for practicing or for avoiding in other settings. Another common question or problem is, should boys learn to sit or stand? And I think it's really helpful starting out if you can teach boys just to sit. And the reason is because sitting is the behavior that's required for a bowel movement. And if we have to teach kids how to differentiate between I stand when I feel that sensation that tells me that I have to urinate, and I sit when I feel that sensation that tells me that I have to have a bowel movement, those are some pretty subtle distinctions for kids to make. And it can be pretty challenging. So if we can just teach them one behavior that applies to all toileting scenarios, I think that sets them up for better success. And later on, if we want to, we can teach boys how to stand. Or if we find that that's just interfering with their learning, it may be that they just continue to sit, which is fine. That's obviously not the end of the world. Toileting-related fears is another one. So this can be a bigger problem sometimes. And oftentimes what we need is other ABA-based interventions. Some of these interventions are things like shaping or fading, which are ABA terms for specific interventions, which sometimes folks are not familiar with. And oftentimes, these are interventions that we should actually do before we start habit training. Oftentimes, we want to make sure that we've taken care of these fears before we start the habit training process. And it may be that that's something that a family would need help from like an ABA therapist or a psychologist before starting to make sure that those fears don't interfere with the process. When bowel training lags behind, in my experience, at least half the time. It's really, really common. And the reason is because kids don't have that many opportunities to practice. With urine, we can load them up with fluid and we can get them to pee 10, 15 times in a day. That's a lot of practice during those 2 or 3 days that you're doing habit training. We can't do the same thing with bowel movement. So oftentimes kids don't put it all together and start having their bowel movements in the toilet. So what we want to do in that case is first we want to rule out constipation. And it's good to monitor this really carefully because kids will sometimes become constipated during toilet training because they're withholding their bowel movement. So we want to be very aware of when they last had a bowel movement. Assuming that kids don't have chronic constipation, the main thing that you want to do to promote bowel training is the same behavioral intervention. So you want to do the positive practice for bowel accidents. You want to reward, anytime a bowel movement happens in the toilet, all the same interventions we've been talking about. And you want to continue those for as long as the child is having any bowel accidents. If a child has constipation or develops constipation, you want to continue all those behavioral interventions with the combination of using laxative, which should be done under the supervision of a pediatrician. So oftentimes when kids have chronic constipation, they're already under the supervision of a pediatrician, and they already have some kind of a laxative regimen in place. But if not, it's not something I would recommend starting without consulting with the pediatrician. But once you do start it, then what you get is a scenario where at least the child is having regular bowel movements. So again, at least you can do the positive practice if it was an accident, or reward it if it was a successful bowel movement in the toilet. And really the data on this, the research on this, are kind of inconclusive. There is one review reference listed here, but whether you should just do behavioral interventions or just do laxatives or do both is a little bit inconclusive still, but all approaches are supported. So I've done it all different ways with kids depending on their scenario, and depending on the role that constipation plays, the combination approach can oftentimes be the most effective. Nighttime continence is another one. How do we teach kids to be dry at night? The most common approaches are reducing fluids near bedtime, um, nighttime scheduled wakening, so where you wake the child up at night to go to the toilet, and oftentimes just waiting for spontaneous progress. Honestly, the majority of kids that I have worked with will spontaneously start being dry in the morning at some point after toilet training. Now, this might take a while. This might not be until a year later, but at some point they spontaneously gain this skill. Now, if they don't, then we probably definitely have to go to nighttime scheduled wakening. And oftentimes people will use this behavioral approach of conditioning, where they use some kind of a pants alarm, or there is a product that's called a bell and pad, which is a pad that the child sleeps on that alarms when the pad becomes wet. And then as soon as the alarm goes off, the adult has to get up and help the child engage in the toileting routine and reinforce them for it. And what typically happens is that the child's awareness increases earlier and earlier in that episode, meaning that they start to wake up earlier and earlier, in their episode of urinating, and then ultimately, hopefully, they'll start to wake up just before urinating. So we're sort of conditioning them to be aware of that while they're sleeping. And that's often a pretty effective strategy. Now, for kids who are really delayed, sometimes they don't gain this skill. Sometimes they gain the skill during the day, and they don't become very continent at night, and they may continue to rely on pull-ups at night. And I would encourage, families of kids whose delays are that significant to still target toilet training during the day, because it makes a really big difference for quality of life, for kids to not have to be in diapers or pull-ups. And even if they have to be in them at night, daytime training is a big deal. So I think it's really worth doing, even if kids don't gain urinary continence at night. There are a couple of pharmacological approaches, and this is not my area of expertise, so I just give these to you directly from the citation that's listed on this slide. People do use imipramine and also DDAVP to decrease nighttime urination. It's pretty effective, but the thing to know about using medications like this for nighttime continence is that the risk of relapse is really high. So they don't teach nighttime continence. What they do is they result in nighttime continence while you're taking the medication, but typically when you stop, then relapse occurs. So where people oftentimes use these kind of interventions is in situations like when kids are at summer camp, for example, and it's going to be stigmatizing for them to be wetting the bed. And so they'll start the medication a little ways before the child goes to camp, give it to them through camp, and then stop the medication when they're home from camp, that kind of thing. But this should certainly be done in conjunction with the physician. So before we wrap up, a few toileting resources. The manual listed at the top, Toilet Training for Children with Severe Handicaps, is the manual that I referred to throughout this presentation. It's also the manual that has the data sheet in it that I showed. Toilet Training in Less Than a Day is the book that I mentioned at the beginning, and it really elaborates these procedures out in more detail. The wording and kind of some of the thinking in these resources is a little outdated, but and what I mean by that is that there's some kind of gender stereotyping, like implying that it would always be the mom who's toileting the child and never the dad, some of these kinds of things, which is a little less contemporary, I think, than where we're at today. But the procedures are the same. The procedures are tried and true. Another great book that has a lot of additional strategies in it is Toilet Training for Individuals with Autism or Other Developmental Issues. This has some information about habit training, but also a lot of other broader procedures and considerations. And then finally, especially for clinicians, the ACAP practice parameter for enuresis is really a helpful resource as well. Here are a couple of toileting supply companies. So the bedwettingstore.com, a couple of medical supply companies. These are great places to get special toileting seats, special stools, special stairs up to the toilet, all kinds of things to make the toilet, as comfortable and secure as possible for the child. And finally, I would like to say thank you. I hope this webinar has been helpful. I think these procedures are really, really effective, like I mentioned, and I'm really excited about the opportunity to share them with other people. So I hope that this has been a helpful source of information. I would also like to note that Simon's VIP Connect has encouraged any additional questions to be directed to their study coordinators, and that email address is listed on this slide. and then responses to the questions will be posted on their website. So that is a great resource for any follow-up questions to this webinar. Otherwise, thank you very much for listening.